Welcome to everyone who has joined us. This is a panel discussion tonight about HIV in the time of COVID-19. I just want to let all the participants know that if you joined and you're automatically muted, so we can't hear you, but there's a question and answer ability at the bottom of your screen to the right. So if you have any questions or comments, just send those over to me and we will get to those in the last 30 minutes of the webinar. So it's a pleasure to welcome all of you here tonight to the discussion on HIV in the time of COVID-19. First and foremost, I hope that everyone here on the call and your families are healthy and safe and managing the best that you can at this really unprecedented time. My name is Katie Mayfield. I'm the Director of Development for the Rutgers School of Public Health. Before I introduce our panelists tonight, I wanted to note that today has been designated as a global day of giving towards the fight against COVID-19. As many of you probably have seen in the news, Rutgers' response to the pandemic has been very swift. We've received national, local, and regional attention to the innovations that are coming out of the school, and very specifically from the School of Public Health. And we'll talk a little bit more about that later tonight. But Rutgers has set up special funds to support those providing care on the front lines of the pandemic, researchers searching for solutions to COVID-19, and Rutgers students who are struggling to make ends meet because of the outbreak. And your philanthropic support, whether you've given or you plan to give, is really crucial to helping Rutgers stay in the forefront of battling COVID-19. So you can join the global fight today by making a gift to one of our funds, and your gift will actually have twice the impact because our chancellor and several other donors across the school are going to match dollar for dollar your gift today. So I'll put a link into the chat feature so that you can make a gift if you feel so inclined. So thank you for joining us. It's now my pleasure to introduce our panelists. Dean Perry and Halkitis will be interviewed by Dr. Stephanie Shiau. Dr. Shiau is an HIV epidemiologist. She joined the Rutgers School of Public Health in the Department of Biostatistics and Epidemiology last fall after completing a postdoctoral fellowship at Columbia University. Her focuses on HIV comorbidities and improving the health and well-being of people living with HIV across the lifespan. Welcome, Dr. Shiau. Dr. Halkitis is a public health psychologist, researcher, educator, and advocate. He teaches biostatistics and urban global public health and is dean of the Rutgers School of Public Health. He is the founder of the Center for Health and Identity, Behavior, and Prevention Studies at Rutgers. For 8 decades, he has examined the intersection between HIV, HPV, and other sexually transmitted infections, drug abuse, and mental health with regard to the biological, behavioral, psychosocial, and structural factors that expose these and other health disparities in the LGBTQ+ population. His work focuses on the effectiveness of tailored and adaptive interventions to prevent and eliminate these disparities. His research program has been awarded more than $30 million in grant funding, and his books are widely acclaimed. Dean Halkitis is also part of Mayor Ras Baraka's Opening and Recovery Strike Force lead. So I'll pass it off to Dr. Shiau, who will facilitate 30 minutes of question and answer and discussion between the two panelists. And then I Q&A from the participants in the last 30 minutes. Welcome.
Thank you.
Awesome. Thank you, Katie. Thanks. So Perry, I thank you for having me here to interview you. And hopefully our panelists will also learn a lot about you and your research and what we're doing in terms of looking at COVID and HIV. So I thought we could maybe start by having our listeners learn a little bit more about you. Do you want to tell us about how you first started in public health and your road to Rutgers?
Well, thank you. Well, so Stephanie, first of all, thank you for doing this. Stephanie and I have had a great opportunity over the last like 6 weeks, like to get to work together, like around issues of HIV and COVID, and it's been great to be able to work with her, and I think it's just the beginning of a collaboration. But so my road to the world of HIV is not a direct one. I'm by training an applied statistician, a biostatistician. I actually finished teaching my last biostatistics class last Thursday to my class. I love teaching biostatistics. I do. I don't just gets me very energized. But while I was doing my degree, it was at the height of the AIDS epidemic, and it seemed to me like what was going on in my life as a young person growing up in New York City, in the New York, New Jersey metropolitan area, who had a career and then who had this activism at night, was that my life was disconnected. So I connected the two of them. And, for the last 25 years, I've been working sort of on the front lines of research, trying to think through how do we bring an end to this epidemic? How do we bring an end to an epidemic that is absolutely 100% virally produced, but we know is socially fueled, very much like COVID, in fact. And I think there's a lot of similarities between COVID and HIV. So when Katie raised earlier the idea that, I'm a researcher and an advocate and an activist, I think that's totally true. I think what I do in my work is really try to answer complicated questions about HIV, try to develop interventions that are actually meaningful for people in their lives and for communities. And as important as all of that, training the next generation of scholars to actually become the researchers of the future. And I was very proud a month ago before we shut down, we didn't really shut down, but we sort of paused and went to our homes and went on WebEx, that my first doctoral student graduated from Rutgers, Kristen Krauss. So, that's what I do in my work. My work is really at the intersection of education and advocacy and research.
Awesome. Can you tell us a little bit about some of the research projects that you've been involved in over the years?
Yeah, a lot. Let me just pick a few of them that I'll tell you about the grant I just submitted today, if that will help, because
sure, we can start there.
Because in the 21st century, you don't just get to be a dean, you have to be a dean and researcher still, because it's just more interesting that way. So I just submitted a grant which is based on a strategy called MOST, the multi-phase optimization strategy, which is a way to try to tailor interventions around health behaviors. And so for a very long time, the idea was that you have this one shop, this one model fits all intervention. You implement it and people's behavior changes. But we know perfectly well, all of us as human beings are radically different from each other. And so you need to tailor interventions, much like you need to tailor the way you teach, right? Not all of our students learn the same way. Not everybody is going to be impacted the same way around health behaviors. How you talked to my parents who are Greek immigrants about health is how you're different from how you talk to me about health. And we just have to keep that in mind. We are not a monolithic population. And so this grant we just submitted is in line with the states and the federal initiative to bring an end to AIDS. And we believe we can bring an end to AIDS by doing a bunch of things. But one of those things is identifying people who are HIV positive, putting them on medications, keeping them on medications, and getting them virally suppressed, which means that they have no active virus in their body, which, is amazing to me, considering what we were witnessing in the 80s and the idea that people can live normal, full lives. But what is even more incredible, and what we have come to know over the last few years, is that a person who is HIV positive, who is virally suppressed, cannot transmit the virus to their partners, even without the use of a barrier. U equals exactly right. Undetectable equals untransmittable. And Bruce Rickman, who is my colleague, who's on our leadership council, was actually the proponent of this. I will say, though, that we as Americans only came to this in 2017 after the Swiss told us this in 2008. So it took us 9 years to catch up. But anyway, if you can keep people virally suppressed, not only is it good for their own health, they have normal, healthy lives with a chronic disease, but then they can't transmit the virus to their partners. So what we're doing is developing an intervention strategy that uses e-technology and mental health counseling through telemedicine and a various combination of things and patient navigation, and piecing it together and testing what is the best intervention for people who are newly diagnosed with HIV within their first year of their diagnosis, to get them on treatment and to get them suppressed. because that first year is a complicated year. People's emotions are all over the place. And so that's what this intervention is trying to do. That's the study I just submitted today as we speak to the National Institutes of Health. But that is, I think, to me, a prototype of the kind of work that I've done. I finished a couple of years ago, a 10-year cohort study where I followed young sexual minority men from the age 18 to the age 26, looking at trajectories of risk and resilience. I have a bunch of work that looks at older adults living with HIV in terms of their, not only their physical, emotional, and social health, but also their grit and their fortitude. Because I think what we often forget is that with HIV positive populations, we focus on the negative, but the HIV positive population also has a lot of strength and power. And how do we build on that strength and power to develop intervention? So that's a snapshot of the kind of work that I've done over the last few decades.
That's a great snapshot. Hearing you talk about U equals U just kind of reminded me how far we've come in HIV, and where we are today with COVID, because HIV and COVID are similar in that there's no vaccines available for either, and there are no licensed treatments for COVID-19, just like there were no licensed treatments for HIV early on in the HIV epidemic. Can you talk a little bit about, the early days of the HIV epidemic and the things that you're seeing now in COVID that remind you of the early days of the HIV epidemic, and how we can learn from history?
Yeah, sometimes we don't learn from history, unfortunately. But what I will say is what's really remarkable to me is that I think that our public health reaction and our ability to actually recognize that we need to isolate and we need to socially distance and physically distance, and our ability to develop an antibody test, and our ability to actually have at least one vaccine potentially in the pipeline, and to have at least one treatment that seems to work in intravenous format for people who are really sick. Oh, that's my dog. Is in fact informed by what we did in AIDS 30 years ago. At the beginning of AIDS, we had no idea. It was horrific. It was scary. Everybody was panicked. I think we have a similar panic now. But the tools, the activism, the antiviral therapies, the public health approaches that developed as a result of the AIDS epidemic, I think have been really helpful right now. I will say, that I think that like HIV right now, which continues to bombard communities of color and the poor communities, COVID is going to be one of these diseases, like very other diseases, that's going to affect those populations more. So I have said for a very long time, and I'll say this about COVID and I'll say it about HIV, these are viruses, but they're socially produced conditions. And so as we continue to fight it, what I guess my big lesson from HIV is, let's not just treat it as a virus. It's not just a virus, right? It's like people's lives and people's circumstances and people's geography and where people's homes are, and the fact that they have to work every single day in a meatpacking plant or somewhere else makes them particularly vulnerable to this disease. So we have to attack this disease on a biological front, on an emotional front, and on a social front and a structural front. And I think that's what we learned from AIDS over the course of the last 40 years. But I want to say one more thing about AIDS and COVID, which I think is remarkable. And I think these data, I talked to another physician yesterday, Stephanie. People living with HIV who are on treatment and have no other condition, have no big diabetes or big other issue, they're not developing full-blown COVID. So it looks like there's some silver lining for people living with HIV and their antivirals, after all these years, who are suppressed, who are benefiting from it right now, which is really pretty remarkable.
Right. And going back to some of those structural burdens, I feel like one thing that we've all been thinking about now is everyone's telling us, stay at home if you're sick, don't go to school, stock up, wash your hands. These are all things that people who are privileged can do. And so many people in our society can't do those things. This assumes you have a home, it assumes you have paid sick leave, it assumes you have a place to go or another place to get food. Can you comment on some of these issues that we are facing and people with HIV are facing?
I think, yeah. So this is probably the most important part of my work right now, and I think a big part of your work, Stephanie, which is like, recognizing that structural inequalities are what fuel HIV and other health disparities, right? And so it's not a surprising. Stephanie and I and a couple of other colleagues had the great privilege and honor of writing this paper a few weeks ago, right, about HIV within a constellation of other health things, including COVID, right? So COVID is just another health burden that HIV positive people face. They face substance use, they face psychopathology, they face HIV, they face violence, they face drug abuse, and all of these things happen together, right? That where you see one health problem, you tend to see other health problems. But what is a really big part of this conceptual model that we put forward, and Stephanie drew a really beautiful image of it, that maybe we could share at some point with the group, is that these conditions, these diseases are fueled by structural inequities, right? So it is not surprising that you will see more obesity, more diabetes, more HIV, more STIs, more violence in poor populations, and often populations of color that tend to not be as affluent as the white population in our country. And so what this says to me is, you're right, we have this great privilege. I'm sitting here, in my home, on this lovely chair, that I bought from Wayfair, by the way, just to be clear. It was on sale. And, yeah, gotta love it, right? It's like we forget that not only when we fight COVID or HIV do we have to fight the virus, but we have to fight those structural inequalities that make people vulnerable to the virus. So I did an interview about 3 hours ago with the Wall Street Journal, and we're asking about Black populations and COVID and their high infection rates, and I was like, why is anyone surprised here? Like, why is anyone surprised? African American populations are put upon all the time, and they experience higher health disparities across the board. This is just another thing in their life. So what this means to me is that you need good laws. My graduation speech this year, which I, by the way, videotaped yesterday outside of my house here, was about how politics and public health are intimately tied. Good politics lead to good public health. Look at Germany. I look at my homeland of Greece. That's my ancestral home. They stayed flat. You know why they stayed flat? Because they had good policies and laws in place. And because if you were in Athens and you wanted to leave your apartment, you had to text to leave. Imagine trying to do that in New York and New Jersey. Yikes. But those things are really, really critical. So beating into those structural inequalities, fighting those inequities, making sure that everybody has a living wage, making sure that children, that families have childcare that they need. All of these things will improve health. It's like, it's not just about a virus, and it's not just about a medication, right? And it's not just about biology. And I think by a biopsychosocial perspective to health means you have to think about all of these things together.
Right. And another thing we should probably talk about is stigma, racism, homophobia, all of these other burdens that are driving and fueling this epidemic and where it's going.
Yeah. So theory that I think you probably Elon Meyer too, right, Stephanie? Elon Meyer's maybe you didn't intersect with him at Columbia, but he's a colleague of ours. He's in LA right now, UCLA at the Williams Institute, and he was a big proponent of this minority stress theory that I think is a lot like syndemic model, that basically proposes that individuals who experience multiple isms, right, have worse health outcomes. So why, gay men experience homophobia. Gay Black men experience homophobia and racism. Gay Black poor men experience homophobia, racism, and economic injustice. And the more stressors somebody has in their lives, the worse their health is going to be. And the literature plays this out completely. And so fighting those, it gets back to the point I was making earlier, fighting those structural inequalities, fighting those isms, right? Those homophobia and racism and sexism and all those isms is a big piece to actually improving health. And we've known from colleagues of ours and from others that in countries and in cities and in states where laws and policies are enacted to, for example, enhance the health of LGBTQ people, that protect their rights, the health of LGBT people increase and it gets better. right? This is not a shock, right? Seems so logical to me, but I think that when we're so stuck in a biomedical model of health, we forget that these social conditions are often the root of the disease. And so, yeah, I mean, I think, look, I have said for the last 20 years, we fight HIV with a three-class combination of drugs because it attacks the virus in three different places. You want to do HIV prevention, you better attack it in three places too: biologically, behaviorally, and psychologically, and emotionally, and socially and structurally.
Yeah, for sure. So what do you think the role of public health is in all of this? Where do we stand?
What do I say to our students all the time? If public health is an activist discipline, if you don't want to be activist or an advocate, you're in the wrong place. I think what we do in public health, which is different than clinical care, is that we think of the health of populations, and we think about the factors that place populations at risk. So doctors and physicians often treat and then nurses and other healthcare providers treat the individual patient, but we're thinking about what is it that makes a population at risk. And when you use that perspective, that population or public health perspective, which Halkitis will argue in 2020 in an upcoming paper are the same thing, you're basically thinking about all of those structural issues. And that's what we have to offer here, right? We have to offer here the training of a generation of public health scholars that are really embedded in this social justice and health equity perspective, that recognize to fight disease, you have to level the playing field. And I think that is what we have to offer. And even though this is this really challenging moment for our students and for many, many people, I think this is a great learning moment. I mean, it's like so many of our students, I'm so proud of our students. I mean, we have over hundreds of students, over 100 students who have volunteered their efforts to work with local departments of health and to do work on the hotline. And so our students are stepping up. And I love what goes on in our classrooms. Don't get me wrong. I think it's amazing. And we have like amazing faculty like Stephanie in our school now. It's like, which is great. But what you learn doing the work in the front lines is invaluable. And so they are getting an experience that is tremendous right now.
Yeah, for sure. So going back a little bit to people living with HIV, how do we think that they are being impacted by the COVID-19 pandemic?
Yeah. So other than the one benefit, which is if you're undetectable and relatively healthy, you probably have protection. Most HIV positive people, who, by the way, in our country, for those who may not be aware, close to 70% of people living with HIV in our country are ages 50 and older. And 50 is the beginning of old age, I sadly say, as a 57-year-old. But that's how it's demarcated. And so we know after the age 50, other health disparities, other health conditions emerge: hypertension, other cardiovascular events, cancers, and what have you. Those HIV positive people, right, most of them are over age 51, are experiencing potentially other health conditions that put them at risk, are, because of their age already and the ageism that exists in our country, isolated because of the fact that so many HIV positive people are either have come from backgrounds that are not economically wealthy, or have given up their jobs and their careers because of HIV, right? We're dealing with people who have limited means, right? Who really are isolated and don't have huge social networks. And my doctoral student, and now Dr. Kristen Krause, has talked a lot about the role of social isolation and loneliness in HIV positive people. And that's going to have a negative effect on the well-being of folks, right? I actually think it's also really interesting, and Stephanie and I are also working on this, is how does HIV care change in light of what's going on right now? So like, how does it work when you do telemedicine, when you need to have a blood draw every 6 months? And I think that doctors and nurses and frontline health providers are trying to figure this all out. But if you're an HIV positive person, you need to see your doctor maybe three or four times a year to make sure you're maintaining your viral suppression, to make sure nothing else is emerging. It's kind of hard to do that right now, right? People aren't allowed to really leave their homes. How are people getting their blood work done? So I think it's a complicated time for HIV positive people, emotionally, socially, and also potentially physically. And I weigh that against the slight benefit potentially bestowed among those very healthy HIV positive people who are on antiviral medication. But let's remember one very important thing. For every 100 people in the United States who are living with HIV, 20 do not know, right? And those 20 are the most vulnerable because they are living with unsuppressed virus. Their immune system is being wrecked, and COVID-19 is bound to have very negative effects on their well-being.
Yeah. So I was thinking the other day, the AIDS 2020 conference, which takes place in July, which has now moved virtually, I think they designated their theme this year as resilience. I wonder if you could comment on what resilience means, both in the context of HIV and maybe even COVID.
So I'm going to steal a line from Kristen, who has said in her dissertation, the psychologists have been thinking about resilience for a long time. It's time to bring it into the public health world. And she's right. And resilience was a concept that developed in developmental psychology as a way of understanding how children from very challenging backgrounds were able to come over adversity, right, and survive, right? And resilience has gotten a lot of attention post 9/11 in particular, when you look at the resilience not only of people, but of cities like New York, like that came through that and are in some ways, I don't know, better is a complicated word, different, but came through it in a way. And so a resilience perspective is a perspective that says, stop focusing on what's wrong and start focusing on what's right. So for a very long time in public health, we have developed models based on what is called deficit. So, okay, so like 30% of people have a drug addiction. Let's make believe. Let's make up that number off the top of our head. So we develop interventions for those 30% of people who have a drug addiction, as compared to trying to figure out what is the 70% doing right that doesn't make them have a drug addiction. And so a resilience perspective sort of turns things upside down and says, look at what's right, don't look at what's wrong, build on strength, don't build on deficit, right? Sort of like, I go back to a school model, everybody. I'm sorry, when I was doing my PhD, I was a school teacher, which I loved, a job I loved. By the way, Lin-Manuel Miranda, the writer of Hamilton, was in my class. So, okay, yay for that. It's like you build on this idea that, people, like you with students, like a student might not be good at math, but they're good in something else, right? And you build on that strength. And so this is what the idea of resilience is. What do you find about individuals that are a strength in their lives that they can use to help their lives get better? And that's what the resilience model is. And you know what? I'm really proud. I've never had an oral paper accepted at the AIDS conference ever. I've always had posters, and Kristen has an oral presentation, which is absolutely remarkable. Awesome. So I'm a very proud papa. It makes me really, really happy.
Okay, I think we can maybe go back a little bit, back to our paper and the conceptualization. So I don't know that we actually worked on the word syndemic yet, or talked about the word syndemic yet. And I wonder if you can tell us about syndemics and how that has framed some of your work in the past, and how we have now taken it to look at HIV and COVID.
Yeah, syndemic comes from, it was a concept developed by Merrill Singer, who's an anthropologist at the University of Connecticut, and he was trying to understand why in the early 90s, why is it that, urban poor people have worse health HIV outcomes? And, he postulated this theory from this, not a theory, but this model from a anthropological perspective that basically argued what I said earlier, which is that when there's one health problem, there's multiple health problems. Where there's one epidemic, there's multiple epidemics. And those multiple epidemics are from the Greek syn, SYN, multiple syn, interacting epidemics. And what syndemic theory argues, that's one part of the model, which is that these health problems fuel each other. Where you see mental health, you see drug addiction. Where you see drug addiction, you see HIV. Where you see HIV, you see abuse and victimization. And that if you're going to treat health, you can't just treat one health problem. You have to treat the whole person. And the whole person has multiple health problems, right? So that's one piece of the puzzle. The other piece of the conceptualization is that by By the way, they're also called in literature comorbidities, right? Right, things that happen together. Syndemic is like a fancier word for comorbidity, right?
Yeah, I guess
think what
syndemic probably includes the burdens also.
Yeah, it
in
includes
some sense.
That's right. That's right. And you know what it does also? Syndemic also, as compared to comorbidity says that drug abuse and mental health problems
They
happen
exist
in
separately.
tandem. Yeah, and they happen
versus
right.
they fuel each other to
Synergistic.
become something more.
Right.
Yeah.
Right, right. Bad depression leads to bad drug addiction. Bad drug addiction leads to bad, like they synergize each other, they catalyze each other, they make each other worse. So that's a piece. And then you're right, Stephanie. The other piece is so those syndemic conditions are fueled by these psychosocial burdens, right? The homophobias, the bad laws and discriminations, the loneliness, and that when you have a lot of those, and the literature is pretty, full of evidence that more of those problems lead to worse syndemic outcomes, right? And so if you are to address these health problems, you've got to address these drivers of these health problems, which are the psychosocial conditions. So that's what a syndemic conceptual model is. And it's a social, I think it's a social justice model. It's a biopsychosocial model. It's a model that recognizes that people are not more than just people are, as I've said for a very long time, HIV positive people are more than just vessels containing a pathogen, right? And often HIV positive people are treated as vessels that contain a pathogen. But you know what? Their mothers and their children and their employees and their spouses. And, if you want to help HIV positive people get better, you deal with the whole person. And I think that's what the syndemic model really makes you think about the whole person.
Right. And we're going to be seeing that with COVID also.
Yeah, I mean, COVID is just, so take 20 bubbles and have them interlock. Let's add another bubble here, right? It's like that with the health problems, it's going to fuel each other, right? One of the things that has not been thought about in COVID, I have this great honor that the mayor of Newark asked me to lead this public health task force of the, strike or whatever it's called, the recovery committee, the strike force recovery. Sounds like a Star Wars thing, right? Right. It does. But I'm really, really, really honored about this, right? Because one of the things I think about all the time around COVID, and we talk about prisons and we talk about meatpacking plants and we talk about frontline staff and workers who have to go to their jobs because they have no choice. I can't tell you, I went to the supermarket for the first time in ages this weekend. I could not thank the cashier enough, right? For her effort to be there, right? While I get to live my little privileged life in my home, right? So it's like she's going out every day and doing that job. But one group that we are not talking about, and we should be talking about, is people who are homeless. What are they doing? How are they getting infected? They are so put upon already. And we know, Stephanie knows this, and a lot of people know this, that a lot of LGBT youth are homeless. A lot of LGBT youth are HIV positive, and they become particularly susceptible to things like HIV. Like when I walk through Newark Penn Station, there's so many people. You can't tell me that those individuals have not been exposed to COVID. And then where are they getting help? Where are these forgotten people getting help? And so I hope that we're going to be very, very adamant in our recommendations in the city to really address the public health needs of that segment of the population that I think the media has completely forgotten.
Thank you. Okay, so I think we're going to pause there, and I'm going to turn it over to Katie Mayfield, who I think will moderate questions from the audience.
Thank you so much, Dr. Shiau, for asking those fascinating questions and really hosting that discussion with Perry. Dean Halkitis, we've had so much participation from our attendees, and they have so many questions, and I'll ask the most pressing one to start. Did you go to school with Lin-Manuel Miranda?
No, I taught him. I was his teacher. So here's the story. I think it's just helpful. Like this, I tell this story all the time because to my students, because I'm like, the most interesting path to your career is not the straight path, it's the circuitous. Right. And just like going where it takes you. So I thought, like the child of Greek immigrants for my whole life, I was going to be a medical doctor. And I was at Columbia doing my undergraduate degree and took my MCATs and did really, really well. And was sitting down getting ready to apply to medical schools. I'm like, I don't want to be a medical doctor. I can't be a medical doctor. This is not for me. Right. This is not what I meant to be. Right. And I knew I was interested in health, but not that way. And so, back in the day when you like finished college, you got a job. I'm not like a millennial, right? So like you had to like have a job, right? And so I decided to teach school, right? I was a science teacher and I was at the Hunter College campus school, which is like an amazing, amazing, amazing school of like gifted and talented kids. And Lin-Manuel was in my class. And and that was pretty amazing. And and I correspond with him now, and it's really great to have seen his career take off, because he is really rooted in the social justice life. So he wasn't in my class. He's a younger man than me, than I am. So I was his teacher, although I was a very young 20-something teacher at the time.
Dean Halkitis, is always fascinating to learn the people who are in your social circles throughout all of your activist life and the many things that you've done. Thanks for clarifying. So talking a little bit about people who are co-diagnosed with HIV and COVID-19 in this moment, are you considering doing research with this population? And also, can you talk kind of about the silver linings that we've been hearing about HIV positive folks who are experiencing less harmful effects of COVID-19?
Yeah, I mean, I think we want to. I mean, I just actually like minutes before, well, I don't know, an hour before we got on this, I sent Stephanie a call about a grant, a PCORI grant, which is like to look at how healthcare delivery changes in light of COVID-19. And I think it would be really interesting to examine that from a research perspective. The other things that I'm doing right now is we're trying to launch a study on the psychosocial and emotional burdens of people living with HIV around COVID. So that's another thing we're looking to do. And like we just got finally approved for the final steps today. We are launching a huge national study on LGBTQ health and COVID, because there's nothing been done in that regard. So lots of, yes, research, of course, like always timely research. It's really interesting because when I was at NYU for 20 years before I made the very wise decision of coming to Rutgers, which is like the best decision I ever made in my life. And while 9/11 was happening, I had one of my NIH studies going on then, and it was a study of medication adherence. And what was really interesting, we published papers on this, is like so for HIV positive people, after 9/11 happened, they're taking their medications like really just got worse, right? And that's not surprising. It's like, it felt like in New York, this was in New York, it felt like there was no hope, right? So why would you take your medications? Like, who cares? Like, the world is coming to an end. I'm really worried this is happening again now, right? I really worry that HIV positive people who are bombarded with hopelessness may be not adhering to their treatments. I worry that HIV positive people who experience these syndemic conditions are engaging in risk behaviors again. So yeah, I think with stress, these things, and I think it's really important for us to understand them and intervene on them in a real time basis.
So follow-up question, why was it the best decision of your life to come to Rutgers?
Oh my God, because the people are so much nicer. No, it's totally true. Look, I loved my career at NYU. I thought it was really, really amazing. And I had a great run there for like 19 years, almost 20 years. But there's something about being at a state institution that trains a lot of students who are first-gen scholars like me. Like my parents had a sixth grade education, right? And I got my education through Columbia and then through the public school system of CUNY. And so for me, giving back in that regard feels so good to me. And I've also got the opportunity to really build something really interesting here at Rutgers. I think New Jersey is forgotten a lot because it exists between Philadelphia and New York. And so I am dedicated to making sure that stops happening and people start knowing that we are New Jersey. New Jersey has its own issues. They're different from New York. They're different from Philadelphia. And we can be the best public health school that draws students from our own state, but from around the country. So I'm just a happy guy. Like, I'm like whistling when I wake up and go to work in the morning, most days.
And Perry, I know personally that you are also a philanthropist and that you really honored your journey and your parents' journey by establishing a scholarship for first-generation students. So thank you for that. Someone asked, what have you learned about yourself and our students during this pandemic?
Wow. I want to say First of all, I said how incredibly proud I am of our students, but I'm also incredibly proud of our faculty and our staff because we've continued just to function, like without missing a beat, like boom, we're still going, like nothing's missed. One of the blessings, if there is such a word, of having lived through 9/11, which I did, and see the towers fall from my apartment, which sadly I did, was to be prepared for anything. So as this was all rolling out in February, I remember writing to my leadership team and saying, we got to be ready here. This does not look good, right? And I think we were like, once the school was physically closed, we were ready to go. So what I've learned about us is one, resilient, two, flexible, nimble, willing to accommodate and take care of each other. I just had the greatest time in the world the other day. I'm such a nerd. I woke up and I did my take-home exam for my students, which in my biostats class, and I made a COVID exam up. And it was just so much fun for me to make up that exam because it's all about COVID. And what I think we've been doing really, really well as a faculty is trying to embed this learning moment into our courses. And so I think things are going to be different moving forward, right? And that's okay. Like, I think it's all right. Like, institutions of higher ed have been functioning a certain way for like centuries. Maybe it's time to do business a little differently. And this, I think, forces us to think that. I think what it also forces us to do is be really creative. I am dedicated to my teaching. I love teaching. I love it. It's like my favorite 2 hours of the week are when I'm in the class. I love being with students. I think it forces us to be much more creative in how we teach this whole situation, and having to be more accommodating and having to be more attentive to our students' particular needs. And I think that's just going to be ultimately a benefit of all of this. So I'm going to say one last thing. Having lived through the 80s as a young gay man in New York City made me learn how to be an optimist, because otherwise I would be crying all the time. Right. So I tend to see like the good in things. Right. And because I could go to bed every night and cry about what's going on with COVID, but I hold on to what is going to come out of this in a good way. And that's I think one of those is the way that schools are going to change and be even better. And public health is going to continue to get the attention it deserves.
So you're talking a lot about changes in higher education, and someone asked, what is really the post-COVID-19 research horizon for HIV? What is that going to look like post-COVID?
Different. I mean, it's changing anyway, right? Because asked me, I said, I've used this line too. If you've asked me 20 something years ago, what do you do? I would say I'm an HIV researcher. And if you ask me now, I would say, well, I work on sexual and gender minority health and their health disparities, of which HIV is one thing, right? And I think all of us, including Stephanie, would say that we've embedded HIV within a larger constellation of health issues we're thinking about, drug addiction and what have you. So I think HIV continues potentially to be a funding resource, but embedded within a larger framework. It can't just be HIV. AIDS exceptionalism is over. Those days are done, right? Especially now when we have medications that it looks like control the virus. I think that's true.
So you're on Mayor Raz's strike force to reopen Newark, and of course the state is looking to reopen as well as the country. What kind of policies are you going to be advocating for on the strike force? You mentioned the homeless population. You've also mentioned the structural disadvantages that we've really learned from in the HIV/AIDS epidemic. What can we do in terms of COVID-19 in this moment from those lessons?
Well, I want to advocate for one thing for sure, which is antibody testing. I don't think we have any idea how widespread. Look, I know the antibody tests are funky and stuff like that. I get it, right? And there's no perfect metric right now, but I don't think we have any idea how widespread this disease is, right? So as a public health person, I want to know that first and foremost. I want to know how widespread it is, where it is, and therefore then make decisions based on that about what needs to be closed down and stuff. So that's one thing. The other thing is, I think measured approaches are needed, right? And I think that baby steps are needed. You just don't say, surprise, we're open, right? That you do things in a methodical way, and each step of the way you measure. Like I'm a statistician. if I see deaths going up, if I see infections going up, which by the way, I think we're going to see in this country, like in the next month until we know it. But if we start seeing that in Newark and we start seeing that in New Jersey, then we've got to retract. So I think until there is a vaccine in place, which is, I don't believe January, quite frankly, but maybe, that we have to just, it's iterative process. Open, watch. Okay, that works. Maybe open a little more, watch, right? And then eventually you've got things looking a little like, although I don't think anybody's going to a Taylor Swift concert anytime soon. It looking, and that I'm okay, and I'm okay with that. But just to be clear, everything's looking a little more like it was before. But I don't think anything is going to look exactly like it did before ever again.
Perry, what kind of effects are we expecting or are we seeing in terms of HIV transmission as a result of social distancing and quarantining behavior?
I love this question. Oh my God, I wrote this right after we shut down, where I was screaming at the apps, right? Because the apps where people go to meet each other, the sex apps, where there was this little COVID-19 message like, wash your hands. And I'm like, really? Because I think that there's other stuff we should be worrying about right now on this app where people are trying to have sex with each other. So I think people are still engaging in risk, but I think a lot of people are not. So I think just like the atmosphere has gotten better because the cars aren't driving and the planes aren't flying, that I don't think that in this particular moment there's a lot of risk going on. But I think the moment you open up the floodgates, there's going to be this wide array of risks that goes on. And there's going to be sort of like this, like, when there's like sort of like a huge snowstorm, or when like when there's a blackout, and then 9 months later there's like a bunch of babies, right, that are sort of emerge, right, because people needed to do something to entertain themselves. I think we're going to see, when the things open up again shortly thereafter, a huge spike in risk. We see it in our studies seasonally, that in the summer there tends to be infections right at the end of the summer increase because people are out. And in the winter, when people are not out, like, and it's cold and they're more isolated, it doesn't happen as much, right? So I think that's what's going to happen. But I think right now, I think in New York and New Jersey, I think people are being, I think people are learning to engage in their pleasure in different ways than they had before.
And are there studies going on at the Rutgers School of Public Health on some of the...
Me.
Yes.
Me.
Okay.
Yes.
And Dr.
Yeah.
Krause.
I mean,
yeah.
And Dr. I actually went today, I beta tested the survey, and we ask all of those questions. Like, and Stephanie will like some of these questions too. It's like we ask them about their HIV meds, if they're skipping doses, if they're having a hard time taking their HIV meds, if they're engaging in which drugs they used in the last year, and then which ones they're using more or less post COVID. So we're getting all that behavior, and sex risk also, right? So yeah, we're gathering that data. Yeah, and it'll be interesting to see, and we're trying to do it on a national level, because I bet there are geographic differences. Like, there's got to be geographic differences. Like, like everybody's out in Georgia, right? So it's going to look different in Georgia than it's going to look in New Jersey and New York.
Yeah, that's really interesting. So we're thinking a little bit about like how social isolation is affecting transmission. And you touched on this. How is social isolation affecting mental well-being for a population that may already be socially isolated? And what kind of mitigation efforts are you seeing in the community?
This is a great question. So I want to first say that mental health is health. It's health, right? We got to stop saying mental health. It's health, right? Because I think when we do that, it's sort of like community engaged research. No, it's just research. Like, why do we need to put this label on it, right? Okay, you know what I'm saying here, right? So we know that for people who are alone, this is a very difficult time. I think that we are seeing mental health burdens, and we see do not have. Paul Duberstein was one of our chairs, who's a psychologist, notes that there is not enough trained clinicians to deal with these issues, during COVID and post-COVID. I think that there are strategies people can use. I actually did an interview today with Equinox Gyms. I'm just going to own the fact that the one way I spoil myself is that, right? I allow myself to have an Equinox Gym membership. It's like my one gift to myself, right? Which I miss desperately, this gym. But I will tell you, one of the things I said to this person who interviewed me this morning was like, routines are key, right? So like the first week and a half when we were out, like I was sleeping late and I was like all funky and stuff. But I've learned now, get up at 7 o'clock, take my shower, eat my breakfast, do my routine, sit on my computer. Actually, like when I finish with y'all today, y'all, because I'm from the South, right? When I finish with y'all today, I'm going to go to the other room and I'm going to do my, 30-minute Metcon conditioning class. And then I'm going to ride my bicycle, and, get my exercise in. So those kinds of things, those kind of physical things are really important to individuals' social health and their emotional health. And I think, look, I think that, what we have to do is reach out to people who we know are alone. Like, my poor aunt, like my one living relative is my aunt who's like 76 years old. She's very vibrant and really amazing, but she's alone, right? Like she's alone. And so I'm calling her as much as I can to just like chit chat with her about like nothing, like, like a 90-day fiance or some garbage like that, because I know she's just stuck in her house by herself. So I think if there's any lesson we take away from this, is that if you have people in your life who are out there alone, pick up the phone or pick up whatever this is, the internet thing, and get with them and just have a conversation with them, because I think that's going to be helpful.
And I also love y'all because it's gender neutral. So I'm a proponent.
Is that what it is?
Right, yes.
But if I was really
actually
what is that from?
Well, actually, I wanted to ask a question, which is from a prospective graduate student in your program in epidemiology. So we've been talking a lot about the intersection or HIV in the time of COVID-19 domestically, and we know that space and place is really important when thinking about health disparities. And she says that she's from the continent of Africa, and she's wondering, she's seen HIV, ravage places in Africa. What can governments on the continent do to mitigate COVID-19 so they don't see something similar?
One of the great things that George Bush II did was the PEPFAR program. Actually had a huge impact on HIV in the continent of Africa. I think we need a similar program around COVID. Right. I mean, we have to be able to provide resources and tools and technology. It's not there yet in the way it is in the rest of the world, but it's just a matter of time before it's there. Right. And so providing that kind of programming and providing that kind of economic support be really key. Again, like, look, so much of the continent of Africa is, in these economically dire situations, and people don't have a choice but to leave their homes. Right. So they're bound to get infected. They're bound to not have access to the good health care that they need. And so we got to keep our eye on that. And I think we have an obligation as a global world. I think if anything, we've learned that we are so tied to each other right now that we've got to help each other. Right. And I remember somebody asked me a few weeks ago, what is one of the lessons that I think that, we go forward as a global world? And I think it's like, we have to have one set of rules we're all playing by, right? Because if we don't, this thing is going to happen again. And so, yeah, it's a really good question from our student. This is, I think, like, look, it's like everything else. Like, where I think we're going to see a lot of death in this country? In the South, in poor Black communities of the South, where, by the way, if you want to know where HIV is right now, that's where it is also. And so we need to intervene there as quickly as possible, even though those places are not as densely packed as New York. But we know from epidemics, even the HIV epidemic, and the HIV epidemic began being distributed along the socioeconomic spectrum. Rich people got HIV, poor people got HIV, middle class people got HIV. Now it's lodged mostly in poor people. And that's what happens with epidemics. And so Africa is something we have to keep our eye on. And the South is something we have to keep our eye on. Dallas had the most hospitalizations and deaths in the last 2 days than it has before. So it's just the beginning, unfortunately.
Okay, I was going to go somewhere with that question and transition into another one, but I'm actually just going to ask you, since we're kind of in the last 5 minutes of our discussion, Perry, can you talk a little bit about how folks can stay connected to you to learn more about what the School of Public Health is doing and how to support this work?
Yeah. So, I think that one of the things that thanks to faculty like me and to efforts like folks like Katie and the team we've really built over the last 3 years at their school, like my family, who I miss desperately seeing, right? We had this leadership team meeting every Monday, and it's like, I miss everyone. I miss everyone, right? But it's kind of fun. We have got that Brady Bunch thing going on the screen, right? But one of the things we've really tried to do over the last few years is really make the school outward looking. Look into the world, look into people. And so we have a communications person, Michelle Edelstein, who is amazing. You can stay connected to us in lots of ways. You can like follow me on Twitter, like Dean PN Halkitis, or you can follow our Facebook page for the school or the Twitter page, or you can get on our mailing list, because we are really, really very, very determined at getting our message out. And this Michelle does this like awesome newsletter every month that when you look at it, I'm like, oh my God, I'm so proud of our school. So I would say all of those things, or you just email me and you figure out how you can get involved. We're always looking for people who are interested in our school, to support our mission, to support our students. Katie knows this. Stephanie probably doesn't know this, but Katie knows. Like about 6 months ago, I said to her, you know how Langone is the first free school of medicine to have free tuition? I want to be that school of public health. I want to be that school where anybody who wants to go to it can go to it. And so that's my dream and that's my wish. And I'm really good about writing back on email. Kate and Stephanie really know that. Like I'm like, oh, I write back right away. I'm available if you are interested in learning more or coming for a visit or anything you need. Our school is open. It's an open space that is for everybody. And that's why it's public health, because we serve the public.
So Perry, going back, we were in the last 4 minutes, and I just want to bring it back to the HIV and the time of COVID-19 discussion. Can you talk to us about how this issue of stigma in the United States with HIV positive folks has changed since the 1980s? What does it look like today in the time of COVID-19?
I don't think it's changed a whole lot. I mean, I think, Stephanie said it before, U equals U, undetectable equals untransmittable, right? And all of a sudden, HIV positive people don't feel like they're like this like walking body of virus anymore, and it destigmatizes. And the work we've done around U equals U has been really amazing, because people feel like so much less burdened, right? So for a very long time, it was the responsibility of the positive person to make sure the negative person doesn't get infected. But now we have these tools, right? Which is like, you can be virally suppressed, you're not infectious. Your partner can be on PrEP, that prevents them from getting from HIV. The burden is equal. But I think there's still a lot of stigma around HIV. I do. And I think that it's one of the things that, stigma around HIV, stigma around race, and stigma around gay identity are factors that fuel the epidemic, that continue to fuel the epidemic. And that's why I think we see young gay Black men being at particularly high risk, because they're getting it on multiple fronts. So yeah, no, I think the stigma's still there. Thank God the death sentence does not have to be there anymore. But I will tell you that people in the world, the larger world, not the Stephanie and Perry and Katie world who live in HIV world all the time, they still have a very, very strong and negative reaction to issues of HIV. And so I don't think it's that much better than it was 40 years ago, quite frankly. And certainly, we like to blame people, right? It's not that the things that Stephanie and I talked about, like structural inequalities, social injustices, discrimination, people just think that people just behave badly. That's what causes them to be sick. But that's not the case. Nobody wakes up and says, I want to have HIV. Nobody wakes up and says, I want to have diabetes. Nobody wakes up and says, I want to have a drug addiction. That's not the way it happens, right, folks? It's not like, oh, I'm consciously deciding to have an opioid addiction. No, life gets them there, and social conditions create those lives. And so, we got to keep pushing that message every single day, because that's the message of public health.
So I want to thank both of our presenters, panelists, question Q&A people on the line, Dr. Shiau and Dr. Halkitis. And I'll just give you both a final question before we wrap up for both of you to answer. Are you wearing pajamas, bottoms, below your suit tops?
Stephanie?
I am not. I'm wearing jeans.
Okay, I am so wearing sweatpants under my shirt and tie, and flip-flops, so yeah, I mean, whatever. I mean, but the top is dressed up. I'm a little worried about putting my suit pants on, having been in my house for all these weeks and being near the refrigerator. So we're gonna just keep wearing the sweatpants till needed.
I think we can all relate. And I just want to thank the attendees for being here, for asking such smart, interesting questions, being a part of this critical discussion at this time. We will have follow-ups with everyone who was on this call, I think via email. So look for that. And if you have further questions or weren't able to get to your question, we'll be able to follow up that way. Thank you, Dean Halkitis and Dr. Shiau, for participating. Good night, everyone.
Thank you, everyone. Thank you, Stephanie. Thank you, Katie. Bye, everyone. Be healthy.
Bye-bye.